Okay, so our big learning objectives up on the screen, definitely want to review our last module that we covered about shock. So definitely understanding the pathophys of shock. We'll just do a quick review of that. But the real focus is really going to be the management and the use of the hemodynamic drugs in the ICU. Okay, so first, we're going to start off with kind of like a trigger. What statements are true? So out of 1 through 6 statements, and they're on the screen, so I won't read them out. But if anyone has any questions about the clarity of the statements, please let me know. But does anyone have any guesses if like 1, let's say, is a true statement or false?
I would say true for 1.
Okay. What about 2?
False.
3?
True.
4?
Sounds like it could be true.
What about 5?
So 4 is true, then 5 is false.
And then what about 6?
Probably true.
That sounds true.
Okay, so I feel like at Zucker we definitely forget how to do our question or like multiple choice. When one answer is wrong by just a little part, we kind of lose all of it. So that's where it gets tricky. So I definitely wanted to remind you guys that multiple choice is definitely a lot easier than it comes off. So the big difference between 4 and 6 is that map of 65. So Eric, do you want to talk a little bit more about like the difference between the 65 or the 60?
Yeah, I mean, we can barely hear you. Sorry. There are a number of studies, including a study called MAP 65, that indicate 65 is the target, but it's not the target alone. So in other words, you should be looking at what is happening to the patient clinically, and we'll be talking about that picture as well. But this is kind of the standard, at least that we're training to in agreement with Dr. Jafari. You might see other numbers used in your rotation, but so far this is the same.
So like that big difference between
You still have difficulty, I think, because of Zoom's like noise canceling. If you're too far away, you can really not hear much. I didn't hear much. I don't know if others did.
Did anyone else have trouble hearing?
It wasn't the best.
Yeah.
Can you hear me better now?
Other statement. Yep, better.
Can you all hear me better now?
Much better.
Oh, excellent. Okay, technology. What we were saying is the current standard that we're training to is 65 when it comes to mean arterial pressure. You might see different numbers in your ICU rotations, but that's what the standard is at North Shore. There are a number of studies that establish that 65 is the target, but it's not just a numerical target. It's also about what's going on with the patient clinically, and we'll be talking about that a little bit more later in this presentation.
So starting off, who would want to read the first case for me? Oh, thank you.
During an ICU night shift, one of our patients started exhibiting a negative trend in their blood pressure. They are a 79-year-old patient, status post 15 days from a right hip arthroplasty with past medical history of type 2 diabetes, dementia, and BPH with long-term catheter use. Bedside assessment, patient's vitals are 85/60 with a MAP of 58. temperature of 36.8 degrees Celsius, heart rate 99, and satting at 99 with shallow breathing. Their mental status seems decreased from baseline, which is confirmed by the nurse who checked in on him 20 minutes ago. The Foley bag is filled with dark, cloudy urine. And after giving 2 liters of lactated ringer, patient's blood pressure is 90/65 with a MAP of 59. And what med do we want to give?
So what are your thoughts? Let's put it in the chat, I guess, if that's a little bit easier. Jessica, you want to share while you're thinking D, since I appreciate you putting it in the chat?
Honestly, I was just trying to think about like a balanced effect. I was trying to think about what's going on, like probably like a UTI, like maybe urosepsis, and given that 2 liters didn't really bring up the blood pressure that much, I was thinking about which one of these has the most balanced effect and is easily titrated.
Perfect. So yeah, you're right. Norepinephrine is definitely the first line when it comes to definitely treating patients with septic shock. Epinephrine and can be second line, but definitely norepinephrine is a go-to. Oh, whoa. So looking at this, it kind of gave it away a little bit, but looking at just the mechanism of actions, which drugs do you think are represented in this table?
It's a team sport.
I think it's norepi as the one showed, and then epi for the second one.
And then what about that last one?
Is that one dopamine?
Good job. Awesome. So what would be the clinical use that all 3 of them have in common? And let's,
Shock.
what type of shock?
Septic shock.
Yeah, time's taking on to keep moving forward. We have a couple more of these to get through. So septic shock definitely being one that all of them can be used for. Norepinephrine being the top line. Like you said, it's really easy to titrate, very good mechanism of action, very balanced, but it can also have like a quick onset, quick offset. And we'll talk a little bit more about how the onset of duration and the duration of the actual mechanism of action is really important when you're trying to manage a patient with shock. So wanted to highlight the common adverse effects. So like this comes into play and definitely something to keep in mind as you're managing the patient, something you want to look out for. So when you have this patient on norepinephrine, keeping an eye out on the heart monitor, keeping an eye out for any types of changes in like the skin of the patient or any in the IV site. So this is another situation that in the ICU, and it's kind of a common theme that like physical exam is an important aspect of you going to the bedside of a patient. So every time you walk into a patient's room, no matter whether it's just to introduce yourself or really the nurse is saying, oh, we have a concern about this, or the nurse is saying that the patient had questions, you should always kind of do like a quick little physical exam, just kind of making sure that the vitals look good, the patient's like mentating the way that they have been at their baseline, and there's not any like skin changes. Like those are quick things you can do while you're talking to the patient that could also signal to you like big concerns that need to be kind of handled. So if you guys know this, I'll be really excited, but what drug is missing in the septic protocol? So when you have a patient that's having this blood pressure, what's another drug that wasn't on our options, multiple choice options to be included for the septic protocol?
Vasopressin.
So yes, vasopressin is a great addition to septic shock, but also hemorrhagic shock. Dr. Jafari, do you want to talk a little more about the study?
Yeah, I believe it was called the AVERT study. They, for the longest time, the dogma of hemorrhagic shock is the patient is bleeding, blood out, put blood in, right? Mechanistically makes sense. But in the past 10 years or so, there was mounting evidence that giving low dose vasopressors might be beneficial in transfusion sparing effects, meaning that if you give some degree of vasopressor to patients who are actively bleeding from hemorrhage, you might end up giving them fewer doses. And this idea came from some animal studies that showed that once massive hemorrhage starts, your hypothalamus actually releases all the vasopressin, and you become vasoplegic, meaning that you don't have any vasopressin to spare. So if you give them some form of support, you might actually get enough vasogenic tone to counteract the vasoplegia from shock state. And then eventually they did this study. There was a multi-center in hemorrhagic shock that eventually showed that if you do give vasopressor along with transfusions, let me be very clear, treatment of hemorrhagic shock, it's still very much giving blood. It's just that if you want to give some adjuncts, you might give them a little bit of vasopressor to help them be able to actually get fewer units of blood transfusions. Now, that study didn't show any mortality benefit, but in and of itself, I think there's a lot to be said for an intervention that spares some valuable blood transfusion units.
So next question is, if the patient's unresponsive to other medications, what can be added?
Is it phenylephrine?
It is. Perfect. So I wanted to group vasopressin and phenylephrine together because these are two that don't actually kind of have different functions where they don't touch the heart at all. Their big focus is the actual vasculature. So if you're worried about a patient having being more susceptible to some of the adverse effects in regards to the heart, just kind of keeping these in mind, that if you had to, let's say you had a patient on norepinephrine and vasopressin and they still weren't really responding and you had to kind of titrate up a dose, but they had a high level of concerning for some of the cardiac effects, you can kind of increase the vasopressin a little bit more before you have to increase the norepinephrine in the sense of worrying about those adverse effects. Luckily, the nursing staff does most, the nurses at the bedside, I don't want to say nursing staff, but the nurses at the bedside are in charge of the titrations. So they also are great resources while you're on the floors. If you have any questions about why we're titrating a drug or getting this off and on, talking to the nurse that's actually doing that titration is really beneficial because they'll even show you how they're titrating or what they're looking for. So another great resource while in the ICU.
And yeah, recognize that while you're in the ICU, there's one nurse for every. We still can't hear you.
Yeah,
Oh.
I got it.
Sorry. And just recognize that while you're in the ICU, there's one nurse for every 2 patients. So there's much higher staffing ratio and more of an ability to actually engage with them and understand what protocols they're using behind the scenes.
All right, do I have someone that will read this one for me? I think there are only one more after this, I promise.
I can read this. As the night continues, another patient, a male, starts experiencing stabbing left chest along left arm numbness. He's a 57-year-old male, status post 17 hours from on-pump cabbage with a history of hypertension and CAD. On bedside assessment, patient currently on 2 liters of nasal cannula, sitting up in bed, holding his chest with this right arm, breathing shallow and rapid. He notes he is having a bit of trouble catching his breath. Patient's vitals are 84/68, MAP 55, 115 BPM, 36 Celsius, 96%. Patient's bedside ultrasound assessment shows diffuse hypoechoic space within the pericardium with right atrial systolic dysfunction, right ventricular diastolic collapse with IVC measuring 2.5 centimeters with no respiratory variability. While preparing for pericardiocentesis and hanging 2 liters of lactated fingers, what medication do you want to administer?
What are some thoughts?
Would you want to give dobutamine in this case? Like
Okay,
concerning
what's
the
going on?
cardiogenic shock?
If we really look at the why do you say cardiogenic shock?
Well, I was thinking like with the like the cardiac history and the low blood pressure, that would lean me more towards cardiogenic.
Do you think any other shock could be possible? Like recent surgery, recent cabbage?
Oh, and yeah, I mean, it could be like hemorrhagic.
So let's say blood is okay. Like there's no issue with the hemocrit, hemoglobin, all the blood levels are okay. Any other type of shock?
I'm not positive here.
Anyone want to help?
And doctor, remember that an IVC of 2.5 centimeters argues strongly against hemorrhagic shock. Hemorrhagic shock is a subtype of hypovolemic shock. And in hypovolemic shock, you generally don't expect to see plethoric IVC.
Oh, got it.
Would this be obstructive shock because of possible tamponade?
Perfect. So it's a little bit more of like an obstructive shock picture. And so for obstructive shock, norepinephrine and epinephrine are kind of, it's really like whatever you can give the patient. The big thing with that obstructive shock is you have to remove the obstruction to really fix the shock. And remember, the big things with shock is you want to fix the pathophys. That's what's causing shock. So in this instance, the vasopressors kind of serve as keeping your patient stable as you're preparing for this procedure. So it's really whatever you can get in and get in quickly to be able to maintain the patient.
I just had a question about why you wouldn't want to use dobutamine here, even though it's obstructive.
I can answer. Can I? Yes. So just bear in mind that in most of these instances, you don't administer one type of treatment, right? You're doing multiple things at the same time to try to save the patient's life. And they have different onsets of action. Unlike dobutamine and milrinone, epinephrine and norepinephrine are actually instantaneous, meaning that as soon as they hit the bloodstream, they start exerting their effects. Unlike milrinone is actually much longer. The titration, dosing, and regimen for milrinone is every 45 minutes or so. So you do one adjustment, you wait 45 minutes to see the effects. Dobutamine is a little bit faster, but it's still not nearly as fast as epinephrine. And I don't know if Courtney's going to talk about this later on, but basically you can get almost anything out of epinephrine because it's a fairly non-selective agent and it kind of acts on everything. So while you're giving volume expanders to this patient and while reaching for your pericardiocentesis kit, what you can do is you can just put them in an epidural. Does it make sense? It's just faster. Theoretically, you might get some ventricular squeeze out of the dobutamine, but first of all, it takes a long time. And second of all, you're not 100% sure the actual problem is concomitant cardiogenic shock. This more looks like an obstructive mechanical shock because the body of the text does not indicate, despite doing an ultrasound, showing a severely reduced LV function or and wall motion abnormality. So these two things would be signs of a recent episode of STEMI. And then in that instance, you would say, well, this could be acute cardiogenic shock because the patient went into that, then maybe ruptured one of the coronary veins, then bled into their pericardium, then they have a mixed type of obstructive as well as cardiogenic shock. But it doesn't sound like it. The body of the text, it kind of points toward this being a complication of surgery and the patient essentially bled into the pericardium.
The other thing we wanted to just point out here is, and this is a spiral back to the first lecture or session we did on shock, is, you know, since we're Zucker students, we should really try and always use our bedside ultrasound skills, right? So right heart failure, like we're seeing here, or obstructive shock that's impeding filling of the right ventricle, is pretty uncommon, but we should, you know, if a patient is unresponsive to fluid resuscitation like they are here, we should be really thinking to ourselves, why is that the case? Is it because they're bleeding? Is it because they're third spacing? Is it because there is a functional obstruction? And ultrasound is the tool we have in our toolkit to figure that out.
Okay, so now we're going to go back to our common adverse effects. So what do you guys think about the adverse effects for epinephrine? What is like the big one that's like the step one, knowing like you should know at the back of your hand that this is what epinephrine is kind of known for? And step two.
Like ischemia at distal extremities?
Yeah, so like that's a big one, and just not torture you guys, make sure we're on the same page. So that's a big one with that local tissue necrosis with extravagation. So again, big thing to kind of keep in mind that you're watching, like really looking at the IV that you have patients on vasopressors with. And again, like really monitoring the heart, since epinephrine does operate mainly on the heart with the beta 1, beta 2. You want to really make sure that you're helping the heart and not hurting the heart. So keeping a mind on the vitals. What about dopamine? So dopamine's interesting.
Can I interject for 1 second?
Yes.
This is like fresh up off the oven. Just last week in Site of Critical Care Medicine conference, they actually presented the results of highly anticipated Clover's trial, which was basically a look at whether a fluid restrictive approach in treatment of shock is superior to fluid liberal, meaning that you want to give as much fluid you want. Not exactly, but very, very promising in their secondary endpoints. They actually looked at the safety markers. And one of the safety markers that they looked at was the rates of complications from administration of peripheral vasopressors. And in total, they had 500 patients who received in excess of 12 hours of peripheral vasopressors. And only 3 had extravasation, and importantly, none needed any significant vascular intervention. So it's very, very, very important, because for the longest time, we didn't really have, this is still essentially a secondary analysis of a primary target, but it's very promising to know that it's extremely safe to give these medicine in terms of the risk of local tissue necrosis. It's still in the USMLE boards. Please answer accordingly so you can get the right score, but so you don't fail. I guess there's no score anymore. So you don't fail, but bear in mind that the data strongly supports the use of peripheral vasopressors, because that risk of necrosis is essentially negligible. It's not zero, it's very, very, very low.
Dr. Jafari, like step 1's not graded, but step 2 for sure is. There's a grade. All right, so let's go to dopamine. Can anyone think of any of the adverse effects for dopamine? Okay. Just for time's sake. So again, big one with the heart. So that ventricular arrhythmias, peripheral ischemia, cardiac ischemia. So it is nice that a lot of the vasopressors have very similar adverse effects. It's more of just understanding which ones are more likely. So dopamine depending on the ICU you're in, isn't really used as often because it has a high profile for having these adverse effects more often. So using norepinephrine and epinephrine are usually more of the go-to over dopamine because of the risk of adverse effects are just higher in the use of dopamine versus norepinephrine and epinephrine. Okay, and then this is the last question. Who would like to read this one?
I can read it. After a quick break for food, another patient, an 89-year-old male with a history of CHF, status post 3 days from hernia repair surgery, alerts the nurse that he has left-sided chest pain and some difficulty taking deep breaths. At bedside, patient is sitting up, holding his chest. His vitals are 89/50 for a map of 58, 115 beats per minute, 36 degrees Celsius, 96% O2 sat. After hanging 2 liters of lactated ringers, which medication do you want to administer?
What are our thoughts? So what's going on in this picture? I guess we can start off with that. Like what are we concerned about in this patient? How do we feel about their blood pressure?
Should I volunteer someone?
I'm trying to ask breakup questions. So
I mean, his pressure is low. Obviously, like he needs some sort of like pressure support. His map is 58. The vignette is sort of suggestive that he might be having an MI or a different type of cardiac event, given his, or maybe not MI, but like an acute worsening of his heart failure potentially.
Do they look like they're septic?
No fever. Nothing else in the vignette that suggests like an obvious sign of infection.
Pretty close to the time of surgery. Really don't associate that with post-surgical infections and the patient's AFib problem.
Like my initial thought would be that he needs like an inotropic medication. The only thing that was making me hesitate was the heart rate being kind of high, suggests that the heart might be beating okay and not be beating that poorly. But I guess given the rest of the vignette, it suggests that like I guess cardiogenic shock would be the most likely. So, and if we were going to say it's cardiogenic shock, then probably B or A, but probably B would be the first choice treatment.
Perfect. It is B. And I think the thing to focus on is a heart can be beating really quickly. It doesn't mean it's actually pumping out very effectively. So even though it's beating fast does not mean that it's actually doing what it's hoping it wants to do, which is trying to get blood to the lungs and to the rest of the body effectively. So big thing with dobutamine. So looking at these 2 drugs on the screen, which one do you think is which out of if their clinical use is really for cardiogenic shock?
I believe dobutamine is the first one, and then milrinone is the other one.
Perfect. So big thing with dobutamine and milrinone, they're both like big vasodilators. So the other vasopressors within this group are more of vasoconstrictors, but these 2 drugs are great for cardiogenic shock, where it kind of eases the afterload for the heart and increases and really tries to aim to get the heart to pump fast. So these are big adverse effects where you want to make sure that the heart isn't getting hurt, but actually still getting aided by these medications. So I wanted to bring this up because if you guys have definitely started studying Percept 2, so I'm not even gonna pretend like that's a question. But these things definitely have popped up where they give you kind of a vignette, they give you a little advertisement for a drug and then ask you kind of to make summaries about what you guys think are going on. So found this study about milrinone and dobutamine and the use of it in cardiogenic shock, and wanted to have you guys kind of think about looking at this data, what do you think this study kind of found? Like in a statement of summarizing what's going on, what do you guys think is going on?
There's, in terms of the causes of mortality listed there on the bottom left, there's like no statistically significant difference between the 2 drugs.
Awesome. So yeah, there's like no really big difference. So what this study was really trying to see is whether dobutamine was superior to milorone when it came to treating cardiogenic shock. We're going to see a little bit more about like the other differences in making that decision, but knowing that the primary outcomes for your patients, there's not a huge difference from this study for dobutamine and milorone are like, so clinically when you're thinking like, okay, which drug is more effective, this study is kind of letting you know, at least in this population that they tested, they didn't find a significant difference between the two drugs in their abilities to prevent certain outcomes. Okay, so now we're going to kind of talk about the clinical approach to undifferentiated hypotension and shock. So step one, always volume resuscitation. I don't know if anyone noticed, but in all the vignettes, there was always 2 liters of lactated ringers. I love the ICU and the SICU is kind of where I like to be. And in the SICU, lactated ringers is for sure the fluid of choice most of the time. So volume resuscitation is definitely needed for vasopressors. Like if you're gonna try to cause the vessels to constrict, the thought is you need to make sure that there's fluid in the vessels for the constriction to actually really be able to take its great effect. So always making sure that when you're thinking about giving pressors that you are either giving the fluid resuscitation first or during the administration of blood pressors. Another big thing is to determine the etiology of shock. So you could start the pressors while you're debating like, okay, like what type of shock this is. But if you can try to get a better idea of the type of shock, you're able to titrate the most effective hemodynamic drug. So luckily norepinephrine is great and it can be used in multiple different types, but it's always best to figure out the etiology of the shock. So like hypervolemic volume resuscitation, hemostats are preventing the continued fluid loss. Distributive vasodilation with or without capillary leakage, depending on whether it's septic or anaphylactic or neurogenic. And then cardiogenic, so like the heart is having trouble contracting or there's a decrease in stroke volume. And then obstructive, it's like there's a decreased cardio output, so figuring out the best way to increase the output. So even though there's a little bit of differences between the pathophys of shock, some vasopressors definitely can kind of pinpoint and help out at more crucial areas than others. So then you want to kind of maximize the route of administration. So peripheral IVs, I believe Dr. Jafari, if I'm remembering this correctly, can be used up to 12 hours.
It's institution-based, but at most institutions within Northwell, they give you at least 12 hours.
So it can be used up to 12 hours.
Some 24 hours.
So the really like I feel like some thought is that like, okay, like if you're going to give vasopressors, you have to put in a central line immediately. But sometimes the patient might not be stable enough for you to be able to really get that central line in, or in the sense where, okay, we need to get medications in rapidly and getting a central line is kind of difficult at the moment. So giving vasopressors into the peripheral IV is still safe. And can still be managed, but if this patient's going to be on vasopressors for a long time, inputting that central line has more benefit in the sense of decreasing other adverse effects. So kind of making sure that you're maximizing the route. And then you want to maximize and monitor the titration effectiveness. So as you're giving patients drugs, their body gets used to it, either decreases their receptors that are responding to it, or the drug just isn't as effective as it wants to be. Same thing with vasopressor. So even if the patient's completely stable on a certain dose, you do have to continually kind of monitor them, because if they're on it for long periods of time, you might have to increase it just because they're getting used to it. Hopefully that's not the case, but just kind of making sure that as you're approaching shock, that you are making sure that you're titrating as effective as possible with the help of your nurses. And then you want to have frequent patient reevaluations because these drugs do work quite rapidly. So like checking on the patient every hour, every 45 minutes might be necessary to make sure that you are titrating effectively and there's not changes where the patient's going in the opposite direction you want them to go. You want to make sure that there's either stable or progress in how you're managing them on these drugs.
So when we talk about frequently reevaluating the patient, we don't just mean like sticking your head into the ICU room and looking at the monitor and saying, the map is 68, I've done my job. It's really put your hands on the patient, examine them, look at their hands, look for signs of cyanosis, look for capillary refill, look at their catheter bag to make sure there's not oligouria going on, because the patient might have a map that's at the baseline or at the target, but they may still be hypoperfused. So we really need to manage the symptoms of shock.
Remember, humans are pattern recognition machines par excellence. So if you look at thousands and thousands of patients, you would come to this realization where you actually see some clinicians that they just get into a room and 5 seconds in, they can clinch the diagnosis. They can figure out what's going on. And it's not because they have some magical aura around them. It's just that they have seen so many normals that they can immediately spot anything that is out of place, even without thinking about it. It's just pattern recognition. And if you want to get good at it, you should just examine as many patients as you possibly physically can.
Okay. So one of the very first steps to be able to work with vasopressors is definitely to know what they're going to be called in the hospital. So kind of matching the street name or the clinical name to the textbook name. So does anyone want to give it a shot for maybe one or two of them? And then we're coming up to the end, guys, I promise.
I believe norepi is Levocet.
Okay, so we'll put E. Any other one?
And C.
Okay, so we got one for E and C. What about two?
Adrenaline.
What about three?
Neos.
Neo.
Okay, anything else? So I have Neo
The
for
Neos and Alper in one.
and then dopamine.
B. Oh wait, yeah, B.
Okay, and then dobutamine.
G.
Okay, so I think we swapped two of them. So dobutamine is actually Dubrex. So intropin is actually dopamine, but luckily I think clinically people just call dopamine. Out of all of these drugs, dopamine I think is one of the main drugs that just get called by its name. So luckily you won't have to see intropin much, but it is on the bags and wanted to make sure that if you guys did see that name that you guys had a hint to what it could be. Okay, so I'm playing with graphics, but sorry if it's a little confusing, but kind of to get you guys centered. So this is kind of signalizing an onset. So first we have our seconds over here up until like we get to a minute, and then we have all our minutes up until we get to an hour. So showing that phenylephrine, epinephrine work really quickly. Epinephrine takes about 1 to 2 hours. Dobutamine is kind of up there too, where it takes about like 5 to 10 minutes. Dopamine 5 to 10. Millerone can take up to like 15, and then vasopressin can take up to like 15 and 20. And then you have your duration. So looking about like how long these actually last after you give them. So seeing that big difference between dobutamine and milderone, that like you can give dobutamine and it'll come off in kind of the same amount of time that it reacted, but milderone will be on for hour, like at least like an hour, hour and a half. So when you're really trying to make sure that you're not increasing any side effects or stuff like that, even though that study did see that dobutamine and milderone don't cause like help out with outcomes, it didn't really talk about the adverse effects of that patient. So just like another reminder about step 2, and I'm sorry I'm reminding, but it's coming, so I want to not ignore it. That's like they might ask a question about like adverse effects, and like the answer is going to be like, oh, they didn't talk about adverse effects. Like that is a downside of this study. So like don't worry if no is the answer, because that is what they want you to kind of understand, is that their focus was on the outcomes and not necessarily on the rate of adverse effects. But being able to understand that through the route of administration of IV, the different profiles of the drugs help you better understand how to kind of manage them. Like when you're reevaluating the patient, you give a patient vasopressin, you're not going to expect to see a change in a minute or two. Like it could take about 15 to 20 minutes. So keeping that in mind of, does this patient have 15 to 20 minutes of me hoping that a medication works to increase their blood pressure? So that's why like norepinephrine and epinephrine, when something needs to be quickly given, those are the drugs that are given because they act very quickly. Luckily, they are also, they're one of the first 2 drugs to kind of to lose their mechanism of action. So like they're a good drug in the sense where it's quick off, quick on, or quick on, quick off. So if there's like any issues or like, oh, like vasopressin, norepinephrine, epinephrine aren't the right drugs for them right now, like they do have a quick off. So like this is the big kind of getting this understanding while you're managing what drugs you're going to put the patients on. Does that make sense? Okay, and then this is in a clearer, nice little chart format. And then I wanted to give you guys a good picture of how these drugs are working, like different profiles. So keeping in mind that vasopressors, they have multiple receptors. So that means that their mechanism of action isn't just one thing most of the time. So you do have these three drugs over here that are for sure just one thing. They are right on that line, but norepinephrine is a little more in, and then you have this kind of picture of all of them kind of having multiple mechanisms of action. So also keeping that in mind when you're giving this to patients. But also keeping in mind, like especially for dopamine and epinephrine, depending on the doses you give them can have different effects. So like a higher dose of dopamine is going to give you way more vasoconstriction versus a lower dose. And then epinephrine, same thing. The higher you go with epinephrine, the more vasoconstriction they're going to have. And then they also have a little bit more positive inotropy. So keeping in mind like the different effects a drug can have just based on the dosage. So let's quickly run through like the steps of titrating, and then we'll have our Kahoot, and I think we'll be wrapping up in an overestimated time. But our big indications, again, if a map's under 65. So if you have a map of less than 65, there's concern that there is some end organ damage that could be going on from the blood not getting to the major organs like your skin, your brain, your kidneys, your liver, your heart. So kind of making sure that your map's higher, but also let's say you had a patient that was very hypertensive and all of a sudden their systolic blood pressure went from 180 to like 110. That's concerning because their body's used to a certain amount of flow, and all of a sudden that's decreased. That could lead to them experience an organ failure. So the indications aren't as like, oh, it has to be less than 65, but can be very patient specific. So keeping in mind what that clinical picture is. So then definitely have to determine the cause of hypertension, and noted that norepinephrine can be given no matter what if you need to quickly stabilize your patient. So you start with one drug, start with like a low dose. So you don't try to add multiple drugs at once. You definitely can start adding, like a patient can be on multiple drugs at once, but when you're really starting one drug, you want to start with one drug low and then kind of monitor your map so you can figure out where you need to change. Then you really want to monitor the patient. So Eric talked about this a little bit more in regards to monitoring the patient and frequent reevaluation. So like making sure that there's no signs of hyperperfusion, meaning that you should go up on your vasopressors because their blood flow is not reaching where it needs to go.
The other thing we wanted to talk about is, again, these are patients that are critically sick. They're in the ICU. They're getting serial labs. Make sure you're reading those labs, especially make sure that you're looking at their hemoglobin and hematocrit, right? So we could be loading these patients up with fluids, but guess what? Fluids don't carry oxygen. Blood does. And we know, we've heard from, it's been drilled into our heads at Zucker, the possibility of, say, anemia of chronic inflammation. These patients' hemoglobin levels will be slowly slipping down over time as they're in the ICU. Check that hemoglobin level. The absolute threshold for giving blood is a hemoglobin of 7 or less. And, we should consider giving them blood in addition to those fluids to make sure we're perfusing those organs adequately.
And so again, you want to monitor the heart. So both in signs of dysrhythmias or myocardial and in ischemia, like there's continuous EKG monitoring of patients in the ICU. So like making sure that you're looking out for any signs of tachycardia or AFib or any type of dysarrhythmias, but also looking out for any excessive, like really fast heart rate that might signal a myocardial ischemia. Or if the patient's reporting any concerns. So making sure you're checking in with the patient, not only for a mental status check, but also making sure that they don't have complaints that might be concerning in the sense where like, okay, we really do have an issue with the drugs that are kind of keeping you stable, and that means we have to change something else. So really kind of checking with the patients and monitoring them in case you need to go to a different plan other than hemodynamic drugs. And then noticing any local effects. So like making sure that there's no dusky skin changes of like peripheral ischemia for your patient, a very easy thing to kind of check while you're there talking to the patient. And then check the IV sites always, especially as patients are getting tons and tons through those IV sites. And you should always make sure that there's no signs for extravagation, but like you also want to make sure that there's not excessive signs of bruising. Like IV sites, if they get to the point where they're painful, patients, it does take a whole different route for patients in their mental state. So like keeping that in mind, and then kind of monitoring their glucose levels while they're in the ICU. So wanted to just kind of show you guys the similar common adverse effects within all the drugs, some more common than others. Phenylephrine kind of on its own with some interesting adverse effects. So definitely if you have this patient on this drug, really focusing on those end organ hyperperfusion signs is important, especially for that drug. And then just so you guys can understand kind of titration doses and appreciate how the nurses really do handle this aspect, that like there is like titration every 2 to 5 minutes and they're at the bedside making sure that this is good. And then they present to you after saying like, okay, like I've gotten the patient stable, this is what we're on now, is kind of how where your understanding is, but it's nice to know that they're able to do all of this. So being able to talk to them and understand like why they're titrating or this is, again, like I said, a great resource.
Just so you know, at the North Shore, the norepi and epi dosages are communicated weight-based, meaning this is basically that 2 milligram initial dosage would be divided by, I don't know, a typical adult male would be 60 kilograms. So what you hear would be that divided by 60. So numbers are usually 0.05 or something like that. That's where you start, and then you go up by 0.05 or so.
Okay, so just trying to summarize, you have this patient on these pressors. So how do you know when you have to take them off? So when you're reevaluating the patient, their mental status is stable, or at least back to baseline. Their vitals are stable, their MAPs stable, there have been consistent MAPs greater than 65. And then the source of the cause has been handled or fixed. So like just because they've been at least had these stable MAPs, once you take them off the vasopressors, if the cause is still there, there is no telling how fast that patient's going to end up resulting into needing more pressors again. So then you decrease the doses in increments because they might be stable at that dose, and you kind of have to decrease it as you go to not cause like kind of a shock to the body in the sense where it's going to go back to shock, but kind of making sure that the body is kind of handling what it needs to handle by itself as you're decreasing. And then once all the vasopressors and inotropes are stopped, you again reevaluate the patient, making sure that they're actually truly stable off of all of these vasopressors and inotropes. And then that is the end. Is there any question while I bring up the last Kahoot to see how we did? Okay, guys. So no questions. Okay. Start. So similar questions. So hopefully you guys aren't memorizing the answers, but kind of understanding why the answers are what they are. So kind of remembering that vasopressors are really big on constricting the vessels and inotropes are focusing on cardiac contractility. So remember that when you're having inotropes, Dr. Jafari, you want to talk a little bit more about this one?
Sure. Remember, the inotropes are mostly agnostic to your heart rate. They are some adverse effects to the heart rate, but in the majority of instances, you would not have any effect on your heart rate. A CHF exacerbation usually will require offloading the ventricle and giving some positive pressure support and all these things, but in some instances you may need the inotropes. Post-cardiac arrest and cardiogenic shock are fairly easy. You know that there's myocardial stunning in both of them. And really there's the only incorrect indication is symptomatic bradycardia.
Does anyone have any questions about that?
What do you do for symptomatic bradycardia if you don't want to give something that increases cardiac contractility and heart rate?
What will you give?
Yeah, what would you use if you're not going to give one of these medications?
Yeah, either you would use any chronotrope, so either epi or norepi or isopretonol.
Thank you.
So this one's a little tricky in the sense where that like that can cause like a myoinfarction, which can lead to some tachycardia or like a dysrhythmia, but like just like a really fast heart rate is still like an effect of the vasopressors and inotropes. So like that really fast heart rate is still like that adverse effect, but like hepatic congestion is definitely not something that vasopressors and inotropes are going to cause. So again, you would never give inotropes and vasopressors like sub-Q. Like it's definitely either a peripheral IV, a central IV. Like you can give it like an epinephrine shot sub-Q. But when you're administering it to like a critical ill patient, it's time to go straight into the IV. Like when those people get their epinephrine shots, it's usually when they're on their way to the hospital, and it's kind of to stabilize them to get there. But as soon as that patient comes in with anaphylactic shock or anaphylactic issues, like you're putting an IV in, and that's how you're getting the epinephrine in.
Had this not included the word inotropes, then A would have been, or 1 would have been also correct. But there's no role in administering inotropes as a sub-Q.
It's like anyone's game right now. Perfect. Okay. I think you guys are all really close. Wait, did you win
Crushing
again?
it.
It was a close one. It was a close one.
All right, guys. So sorry we ran a little bit over, and so I was a little bit late. Someone caught me in the hallway. I came back to school to do this, so someone caught me in the hallway. But how many of you guys are able to make the session at North Shore at 5? Just so we know who to kind of wait for, keep an eye out for.
I have a doctor's appointment, sadly, so I won't be able to make it. But thank you guys for organizing these. They were really helpful.
No problem. If you want to join them next year as a 4th year, please let me know.
I'll be there. I was just wondering if you have to wear a scrub, because I was at school today.
Dr. Jafari.
I'm sorry, what was the question?
She has to wear scrubs.
I'm not sure. If there's any problem, just call my cell phone. I'll come and grab you.
I'm also not going to be able to make it, but yeah, thank you. Really helpful. These sessions were.
Awesome. Beautiful. Tell your friends. All right, guys. Thank you so much. Good luck in your last trimester. You guys are almost done. 1 trimester down. 4th year gets better after September, I promise, depending on their specialty that you want to go into. But then, come February, it has to get better regardless. But thank you so much for coming. Please let me know any feedback. We'll send out a survey, hopefully, to get any feedback that you guys might have. And thank you so much.
All right. Great job, everyone, especially Eric and Courtney for organizing this. All right, I'll see you in a little bit.
Thanks.